Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
So here's our roadmap. First, we're going to tackle the root of the problem, this whole oxygen supply and demand thing. Then we'll look at the three main pharmacological solutions we have in our toolkit. And finally, we'll see how it all comes together in real-world clinical strategies.
All right, let's get right into it. Before we can even talk about the drugs, we have to understand the fundamental problem, the pathophysiology of what's going on in ischemic heart disease, or IHD. At its heart, no pun intended, IHD is really a conflict. It's a critical mismatch between the amount of oxygen the heart muscle desperately needs to function and the amount it's actually getting. This slide really lays it out perfectly. It's like a tug of war. On one side, you have things choking off the oxygen supply, like a narrowed artery. On the other side, things like exercise or stress are cranking up the heart's demand for oxygen. When this balance gets thrown off, that's when you get into trouble.
So what does this imbalance actually feel like for a patient? Well, that brings us to the classic clinical sign of IHD, angina pectoris. That's the chest pain that happens when the heart muscle is temporarily starved of oxygen.
Now, here's a really crucial point. Angina is the symptom, but there are different causes. You have stable angina, which is predictable. It happens on exertion because of a fixed blockage. Then you have unstable angina, which is an emergency caused by a plaque that just ruptured. And then there's variant angina, which is kind of weird. It's caused by a random spasm in the coronary artery. You have to know the difference because you treat them differently.
Okay, let's get to our first pharmacological solution. We're going to start with a real classic, a class of drugs that's been a cornerstone of angina therapy for well over a century, the organic nitrates. The prototype drug here, the one you absolutely need to know, is nitroglycerin. If you understand how nitroglycerin works, you pretty much understand the whole class.
So how do they do it? Well, nitrates get into the smooth muscle cells of your blood vessels and release a molecule called nitric oxide, or NO. NO then kicks off this signaling cascade that ends with one major effect, profound relaxation of the blood vessel. We call that vasodilation.
And this is how nitrates fix that supply and demand problem. They do increase supply a bit by dilating the coronary arteries, but their main effect, the real magic, is on the demand side. They cause massive venodilation, which means less blood returns to the heart. This dramatically reduces the heart's workload, what we call preload, and that means it needs a whole lot less oxygen.
All right, on to our second tool in the box. This class of drugs takes a totally different approach. It focuses almost entirely on the demand side of the equation. I'm talking about the beta blockers.
The whole strategy with beta blockers is to just calm the heart down. They block beta-adrenergic receptors, which directly slows the heart rate and reduces how forcefully it contracts. The logic is pretty simple, right? If the heart works less hard, it's going to demand less oxygen. You can see here the overwhelming effect is on decreasing oxygen demand. There is a small secondary benefit to supply, though. By slowing the heart, they give the coronary arteries more time to fill up with blood during diastole. This makes them fantastic for angina that's brought on by exertion. Okay, this is a huge, high-yield point for any exam. A major clinical pearl. You cannot use beta blockers in variant or Prinzmetal's angina. Why? Because they can actually make that coronary artery spasm worse. It is an absolute contraindication. You've got to remember that.
Time for our third major drug class, the calcium channel blockers. These offer yet another unique approach. And they're really powerful because they hit both sides of that supply and demand equation. Calcium channel blockers, or CCBs, are a pretty versatile group. They work by blocking calcium channels in the smooth muscle of blood vessels and also in the heart muscle itself. And because of that, they're actually effective in all three types of angina. And this just shows their powerful dual action. On the supply side, they are potent vasodilators of the coronary arteries, directly boosting blood flow. This makes them a go-to choice for vasospastic angina. And on the demand side, they relax the peripheral arteries, which lowers blood pressure, or afterload, and some of them can even slow the heart rate. It's a real 2-for-1 deal.
Okay, so we've looked at the individual tools. Now let's put it all together and see how we actually use them strategically in different clinical situations. This is where the rubber meets the road.
Think of this table as your clinical playbook. For a sudden, acute attack of angina from exertion, you need fast-acting sublingual nitrates. For long-term prevention, you've got options.
long-acting nitrates, beta blockers, or CCBs. For vasospastic angina, nitrates and CCBs only. And remember, no beta blockers. An unstable angina, well, that's a medical emergency that gets you a hospital admission and a whole cocktail of drugs.
Now, in the most serious case, a full-blown heart attack or an MI, the strategy gets even more intense. We give oxygen, we manage the incredible pain with morphine, and we use IV forms of our anti-anginal drugs to try and limit the damage to the heart muscle. But most importantly, we have to restore blood flow immediately, and that's where reperfusion therapies come in.
So, after all this, here's the final thought I want to leave you with. These drugs we've talked about, they are absolute lifesavers. They manage the symptoms, they rebalance that oxygen supply and demand, but they don't do anything to treat the underlying disease, the atherosclerosis itself. And that brings up the most critical question of all. What are we doing about the plaque that caused the problem in the first place?